Now, the last session ran over a little bit, and I was just given permission for us to go to 11:30. I'm going to spend about 25 minutes or so asking you questions, and then we'll have some time at the end for the audience to ask questions. So I'd like you to be thinking about many of the things I forget to ask, many of the things that might be important to you, so you can ask the panel those questions at the end of the session. I promise we'll spend a little bit of time for you doing that. This panel is designed to talk about the key decisions in perioperative management and intraoperative management of total knee arthroplasty. And those of you who were here yesterday will recognize that I ran a similar panel for the total hip group yesterday. I will confess to you that some of the questions are the same, but I have done that intentionally because, number one, a hip is not the same as a knee, and practices are different. You all know that. And number two, because this panel is not the same as yesterday's panel, and we want to get a diversity of comments and opinions, and I suspect some of the comments and opinions might be quite different from what we discussed yesterday. So with that, we're going to get going. Let's see, shall we just run down the panels? Everybody know, just introduce yourselves very quickly, since I can't see everybody well. Peter?
Yep,
Peter, Amar, Rag,
Sachin,
Subramaniam, yep, and of course Ashok. Okay, I think we might be missing one person, but we will make do. All right, ladies and gentlemen, with that, we're going to get started. I will disclose to you that I receive royalties from DePuy on some hip and knee products, and the rest of my disclosures are listed here. We're going to begin by talking a few minutes about indications and preoperative management of patients. First of all, let's talk about body mass index. How many of you on the panel have some sort of a cutoff, either soft or strict, regarding body mass index? Hands up. Almost everybody. Amar, you did not, I think. Is that correct?
Correct.
Okay. And let's just go down the panel and just give me either a strict cutoff and give me a number, or a soft cutoff and give me a number. So soft, 35, strict, 40, whatever. Start with you, Peter.
Soft 45, strict 50.
Okay, fair enough. That was good. Amar?
Yeah, soft 45 at our institution. They have to get evaluated, but I'll do 50s.
Okay, now and then you will if somebody's, let's say, lost a bunch of weight, trying to make an effort. Fair enough.
Yeah, around 40. If more than 45, I consider a bariatric surgery now.
Okay, good.
Same 40 and 45. Soft 40.
Soft around 40 and 45, you're a little stricter, Sachin?
Yeah.
Okay,
Same here, soft 40 and strict 45.
okay, fair enough.
45-40.
45-40, okay.
40-45.
40-45. So it's actually pretty good consensus on the panel. Most people would like to have somebody at around 40 start losing weight, BMI of 40 that is, and around 45 they're going to be very strict about it. Mar?
You know, but we make this point all the time, right? That BMI is just not the best number to measure, right? Where's the fat? You know, is it a man with a big belly and skinny legs?
Totally agree. I mean, where's the fat? And some people can have a high body mass index and not be fat. A big, strong, muscular man may not be, that's short, may not be very fat with a body mass index of 40. So your point's well taken, and I'm glad you brought it up. Smoking. I recognize that there probably are fewer smokers in India than there are probably, at least in European countries. I don't know about in America nowadays. But let me just ask you, right down the panel, starting at the far end. Who's at the far end right past you, Ashok? Oh, they're in it. Yeah. Can you please tell me strict cutoff for smoking or no?
Strict cutoff.
Strict cutoff, Ashok?
Absolutely strict cutoff.
Strict cutoff, okay?
In India, it's many ladies who come in for TKR, so smoking is not much of a problem, not a strict cutoff.
Okay, so that means there are fewer women that smoke in India than men, maybe? I don't know if that's true in North America, actually. Go ahead, yeah, next.
So not a strict cutoff.
Not.
Yeah, strict cutoff, but I don't know how much the patient is going to listen.
Okay, fair enough. Mar?
Yeah, no cutoff.
No cutoff. Peter?
Strict cutoff.
Okay. It's interesting. Smoking is a very easy thing for us to quantitate. We all, I think, as doctors feel as though smoking is bad for people, so we're tough about it. But the data on how much smoking hurts you in terms of outcomes are actually a little bit soft. Nutritional assessment. Which patients and which tests? Starting with Peter.
So had to have some risk factors. I think we talked about it yesterday as
Quick.
well.
You got it.
So I was
efficiency,
albumin.
Peter. Efficiency.
Albumin.
Albumin. And who? Who gets that? The eyeball test?
Eyeball test.
Okay, so if they look nutritionally
Malnutrition.
malnourished, you'll do it.
Malnourished.
Amar.
Yeah, I don't do the assessment. I mean, they get medical evaluations, and that's, you know, they're doing the assessment for
Do you think the medical person knows to look for nutritional problems?
At our institution, yes,
Okay.
we have excellent
Fair enough.
support system.
Yeah, your place, I'm sure that's true.
We
Right.
can make out those patients who are malnourished, they would get proteins and the AG ratios.
Okay, and you'll look for them specifically,
Yes,
Parag? Okay?
yes.
Yeah, Sachin?
Yeah, I would agree with that. I think the patients whom I want to look at is those who've had some history of malignancy. That's one. And
It's a good one, by the way. That's
secondly is
important.
inflammatory arthritis.
Yep, good, both good comments. Yep, thanks.
And really aged patients over the age of 85 and old, we look into it, otherwise no.
Okay?
Hematocrit and proteins.
Hematocrit and proteins, okay, so total protein in albumin, fair enough? Yeah,
Albumin, if it is less or more than 3.5.
okay.
Apart from hemoglobin, the proteins, every patient I assess this. I also assess their vitamin D. And
Okay.
there are two papers that I published and others have, that if their vitamin D is very low, there is a decreased functional outcome.
Right, and again, this is, we've got this problem with association and causality, and vitamin D stuff's a little soft right now.
This is true,
Raj, I'm
Terry.
glad you joined us, though. I thought for a minute maybe we had been so tough on you after the last one that you left.
I think there is a absolutely good evidence that the patients with less vitamin D have, the outcome is down in the fracture neck of femurs and other cases.
agreed.
And it affects musculoskeletal system.
What hasn't been proven is if you replete the vitamin D, that it brings it back to normal.
Yeah,
That's the
but there's no harm in bringing it up.
No,
And-
no,
and-
agreed.
And there is a method of orally correcting it very quickly, and I do it. That's it.
No, I'm not
because you
saying
asked
it's,
and
I'm not saying it's a bad thing to do. I think the only point is that, once again, it may be a marker for malnutrition and other things as much as
And it is a very
anything
simple
else.
thing to do. Apart from
Amar, you had a comment?
Yeah, I just wanted to say, we made the point of, large BMIs being problematic, but so are very low BMIs.
Yeah, that's a good point. In fact, the very low BMI patient has a higher risk of infection, just as the very high BMI patient does. It's a good comment, and I'm glad you brought it up. Diabetes testing, starting with Raj. Raj, what do you do for diabetes testing?
So I look at their fasting PP and HbA1c.
Okay,
My cutoff for fasting and PP is less than 150 for fasting, less than 200 for postprandial. And HbA1c, if it is above 8, then I would wait and see if that can be brought down
Okay.
with a normal medication. And the trend, I would like to see that it is falling.
okay, fair enough. I think what I would say about this, we talked about it quite a bit yesterday, so I won't belabor it, and that is that, would most people on the panel agree that if they're over 8, they probably should at least get medically checked over and tried to be optimized a bit? Yeah, fair enough. And as I said yesterday, the data for joint replacement are that hemoglobin A1C doesn't correlate terribly well with outcomes, but perioperative glucose management correlates very well with risk of infection. So that's been pretty well proven. Somebody have a comment on that? No. Okay. Pre-op urinalysis. How many of you on the panel get a pre-op urinalysis on basically all of your patients still? Say yes. 2 of you, 3 of you. Okay, and the rest of you? And how many on the panel never get a pre-op urinalysis? How many of you get it selectively on patients who have some symptoms or that you're worried about? Okay, so that's definitely been a change in practice, as I described to you yesterday. In the old days, we got UAs on everybody. Nowadays, there's a definite trend, at least in North America, to do it more selectively, since most of the time the results don't seem to change what we do very much, or the outcomes. Staff screening. How many of you on the panel are doing some form of formal staff screening? Actually, about half of you, or a third of you, maybe? Okay. And how many of you on the panel are not doing staff screening, but are treating everybody with either mupirocin or betadine in the nose before surgery? Another 2 of you are. Okay, and the rest of you are blowing it off. Is that right? Okay, fair enough. Your standard antibiotic prophylaxis for a routine primary total knee. Let's just go down the panel, starting with Raj. What's your standard antibiotic prophylaxis primary total knee? Be efficient with your answer, though.
I give 3 doses. I give 3 doses of not cefazolin because of my.
Oh, you got to be efficient, Raj. Quick answers.
Okay, I use Magnix, which is cefaperazone, 3 doses, and a single dose of Targocid
Okay.
preoperatively.
Okay.
Cefazolin for 2 days, amikacin single shot while induction.
Okay.
Second generation cephalosporin.
Okay. Thank you. And that's the kind of brief answer, guys, I want. Did you see how Ashok did that? Everybody pay attention. Okay?
Cefuroxime.
Okay?
Cefuroxime only.
Okay?
Cefuroxime, 1 dose before and 3 doses later.
Okay.
1 hour before.
Okay?
2 grams cefazolin.
Same, 2 to 3 doses, depending if they leave same day.
Okay, and Peter, are you guys giving a weight-adjusted dosing? So if you got a
Yes.
super heavy patient, they get 2 or
Additional
maybe
gram.
even 3 grams?
Yeah, depending on weight-based.
Okay. If you have to use vancomycin or clindamycin because of a true penicillin allergy, will you add a gram-negative coverage to that, recognizing that vanco and clinda do not provide very much gram-negative coverage? Peter, yes or no?
Yes.
And what do you give? Aminoglycoside, 1 dose?
Glycine, yep.
Okay, Ramar.
Yeah, I give a gent 80 milligrams of gent one time.
Okay, Parag.
Same.
Same?
Same.
Same?
Yeah, same here.
Anybody different? Looks like consistent, Ashok, same? Same, okay. If you're using cement on your total knee arthroplasty, and we'll get to whether or not you're doing that in a minute, are you using antibiotics in the cement in everyone, high-risk patients only, or nobody? Let's start with Peter.
High risk.
High risk only, and what's a high-risk patient? Diabetes,
Diabetes.
rheumatoid arthritis,
infection, rheumatoid,
immunosuppression? Fair enough.
obesity.
Obesity, so now you're up to most of your patients.
That's everyone for me.
Okay, fair enough. Amar?
Everyone.
Antibiotics for everyone.
Everybody for you, Parag? Sachin?
Yeah, high risk only.
High risk only?
High risk only.
High risk only?
High risk.
High risk?
High risk.
High risk?
Everyone.
Everyone. So all of them are using it some of the time. About half are doing it in high-risk patients only, about half in everybody. Tranexamic acid, everyone on the panel, I'm sure, is using it, correct? Yes. So let's just go down the panel and tell me what your protocol is for tranexamic acid as briefly as possible. Peter?
1 gram IV, and then a topical when the cement's hardening.
Okay. And how do you put the topical on?
Just pour it in the wound to let it sit. 3 grams non-diluted.
Just let it sit there. So you're putting in there, you're not putting betadine at the same time. Okay? Okay? Amar?
I do the same thing.
Same thing?
So 1 gram IV, then topical. If the surgery lasts for more than 2 hours, then they get 1 more gram.
Gram at the end. Okay? Sachin?
Preoperative, topical, and 1 dose after 6 hours.
Okay? After 6 hours. IV? Oral? IV. Okay?
1 gram IV and then the wash and nothing post-operatively.
Okay?
The same pre-op, per-op, and after 2 hours.
And after 2 hours, you give it. Okay?
1 gram 12 hourly, 3 days.
Say that
IV,
again.
tranexamic acid, 1 gram 12 hourly for 3 days.
So you give it for a long time. Yeah. Did you say for 3 days? Did I understand you correctly?
3 days? Yeah, 3 days.
Wow. Okay. And Raj?
Yeah, so pre-op, intra-op is the local sprinkling.
Topical.
And 6 hours after the
And 1 dose 6 hours afterwards. Intravenously, Raj?
intravenously. Pre-op and 6 hours is intravenous.
Okay, fair enough. Corticosteroids. How many of you are using corticosteroids in some form or another around the perioperative period? Okay. And let's just go down quickly. Do you know what your dose is and what your protocol is,
Yeah,
Peter?
4 milligrams of Decadron for 1 for primary, 1 dose, and I do 2 for bilateral.
Okay. Amar?
Hours apart.
Same? Parag?
So yeah, we give it intravenous just before the surgery, and if it's a diabetic or any other comorbidity factor, then they don't get the
They don't
steroid.
get it if you think they're at risk for the steroid. Okay?
Single dose.
1 dose pre-op. Okay?
I mix it in the cocktail and not in rheumatoid patients.
So you're giving it only in the injection periarticularly, not intravenously. Is that right?
Yes.
Okay? Ashok?
At induction, and we avoid it for diabetic patients and immune compromised.
Okay? Thank you.
Only in periarticular, 2 milligram Kenacort.
Okay?
I think only in the selected patient where the anesthetist for the nausea or any other side effects that post-operatively it needs to be given.
So
Otherwise
you're
not.
giving it only in patients that you're worried about. Is that right, Raj? Not in everybody?
Not in everybody.
Okay, fair enough. The data are pretty clear that IV steroids help with nausea. That's probably the main reason they're being given in the U.S. because a lot of patients are now being done as an outpatient or a single-day stay. And there's also pretty good data that shows, at least in certain doses, it can help with pain. And there's no question that it gives everybody a feeling that they're strong and fast for about 24 hours. Skin prep for a primary total knee. Iodine alone, iodine with alcohol, or chlorine with alcohol? Let's start with Raj.
So
So the brown stuff
Chloro
or the
with
orange
alcohol.
stuff is basically the question.
I think the chloro with alcohol is my choice.
It's your choice. Do you hate the fact that the drapes don't stick as well to that?
Yes.
Okay, it sticks better to the iodinated one.
No, I didn't understand that.
No, I asked, do you not like the fact that the drapes do not stick as well for the chlorinated version compared to the iodinated version?
That's right.
Yeah, okay? Well, slight negative, okay? Who's next?
Iodine.
Iodine?
So we use iodine and alcohol.
Iodine and alcohol, yeah.
Yeah, same here, iodine and alcohol.
Iodine and alcohol.
Same iodine alcohol, that's what we get.
Yeah.
Yeah, we institutionally switched to the yellow stuff, orange stuff.
Orange stuff.
Orange stuff? Yeah. Okay, so it looks like everybody's using some alcohol-based stuff with a halogen. It just depends on which one of the two you're using. Okay, now we're going to discuss a little bit about preoperative evaluation with respect to the radiographs. What do you get for your standard vanilla knee? Do you get just standard stized radiographs? Do you get a standing hip to ankle radiograph in everybody? Or are you selective about in whom you get them? Let's start with Peter.
It's hip to ankle in everyone.
Hip to ankle in everyone. Okay. Amar?
Same.
Hip to ankle in everyone?
If
Parag?
he gets the long leg films, if it is a severe deformity, I will do stress fusion.
Your mic died.
Yeah, so long leg for everybody. If there's a severe deformity, I do stress x-rays to see how much is correctable.
And why do you do those?
So I know which is a fixed one and which is a correctable one, so that impacts my release during the surgery.
Okay. So you don't think you can figure that out in surgery, or you just would like to know ahead of time?
I'd like to know it ahead of time, so.
Okay. Sachin?
Everybody gets alignment X-ray.
Okay.
Standard, in special cases with too much of deformity, hip to ankle.
Okay, and how do you know if they have too much deformity? Is it based on your eyeball, or is it based on history, or is it based on the first radiograph? What is it that tells you that?
Yeah, first radiograph and eyeball.
Okay? I think all of us would agree if you know that they have hip pathology or something else that's going to give them an odd alignment, that would be mandatory. Okay, go ahead, Ashok.
Long leg x-rays for everyone.
For everyone? Okay.
Standard X-rays long only when required in deformities, extraarticular deformities and other cases.
Okay.
So I used to do long leg x-rays before started using navigation for everyone. Now it is only in a very selected group of patients.
Okay, so there's a little cost savings for your navigation or your robotics.
You're getting there.
We got to give him a chance when he deserves it, let's be honest. Okay, tourniquet. On everyone, just for exposure or cementation, or on basically no one? Okay, let's start with Peter.
Exposure to cement.
Okay?
Tourniquetless exposure, then for cement.
Okay?
Tourniquet for everyone.
And so Parag, if they have known vascular disease, will you still use a tourniquet?
I still use it. Yeah, if it's a vascular disease, of course, if I see it on the x-rays,
If
then
you
I
see,
will not,
so you look on the x-ray, the lateral radiograph has all sorts of calcifications.
I will
you
not
do
use
it?
that.
You'll not use it, okay? Sachin?
So all unilaterals will have a tourniquet unless they have vascular disease. Bilateral, the first side gets a tourniquet, the second side is only for cementation.
No tourniquet.
Why do you do that? It's an interesting protocol.
Because once I finish cementing one side, I move to the other side. So,
You just don't want to have two tourniquets up at once, is that what you're
yeah,
saying?
that's right.
Okay, fair enough.
No tourniquet at all.
No tourniquet at all, okay. Ashok?
Only for cementation.
Only cementation.
Everyone.
Everyone, okay.
Tourniquet in 90% of the patient.
Most of the time. Okay, so this is an interesting topic. It's been studied extensively, and the bottom line, I think, has been that the very best studies have failed to show much difference between a tourniquet and no tourniquet. There are plenty of studies that are of a little bit lower quality or with surrogate outcomes that have suggested there might be a benefit of a no tourniquet. Amar?
The only point I want to make is, and the reason why I do a tourniquetless exposure in everyone is for the vascular path, is for those situations where I want to go tourniquetless the whole day. If you don't do it regularly, it's a bloodbath. So you need to build the skill set.
You're right, that it is a skill set to go without a tourniquet. And I think the biggest thing is probably just learning that if you keep the knee flexed, it bleeds much less, right? So that's really sort of the simplest point to remind everybody of. Bilateral simultaneous total knee arthroplasty, do you perform them? And if so, what are your main indications and your main exclusions? Let's start with Raj.
So I do bilateral TKAs in about 30 to 40% of the patients who
Okay.
need it. And the indications are that the patients, the criteria are very important, less than 75 years of age, good cardiac and pulmonary status, that is most important. And the something in between is the hemoglobin level of the patient and overall nutritional status of the patient.
Okay, fair enough. Now, as we come down the panel, unless you have a big difference in terms of what Raj just said about indications, just tell me, do you do them, and if so, what percentage of your patients?
So Dan, strict criteria, less than 75 ASA 1-2,
Okay, and what percentage of your patients would that be that get them?
about 75.
75% of your patients get bilaterals?
Yeah.
Wow. So you're doing bilaterals in all kinds of patients?
Yeah, with deformities, provided they fulfill this criteria, we do
Okay.
it.
Yeah, no, I got that. But what percentage of your total knee population is getting a bilateral total knee?
About 75% of my
Wow,
patients.
okay, a lot of them, all right. Next.
Bilateral never.
Never, okay, so
In single admission,
one guy's 75%, one guy's never, so there's some big differences, okay? All right, next.
Bilaterals, 75 to 80%.
Most of the time, huh? Okay.
Agree around 60 to 70% are simultaneous.
So bilateral, my cutoff is 70, above 70, no bilaterals, and 20 to 25% of my patients are bilaterals.
Okay. Mark?
I discourage it, less than 10%, but if I do it, I'm doing them cementless nowadays.
Okay.
So 10% of my practice, probably half of the patients who are candidates for bilateral get them. but
Yeah, I wasn't
10%.
sure if how
That's
the
the
answer
question.
was coming out. I wasn't sure if the answer was of their practice that you're doing 75% or the people that were candidates.
Candidates,
were
yeah.
Getting 75%. Ashok, could you clarify that point? So you said 75% get bilaterals. Is that 75% of all your knee patients or 75% of patients who would be a candidate for bilateral knees get it?
No, that's my practice. That's what I actually perform.
So he means it. So he means it, Peter.
I mean, I think India has this, they have these, bilateral deformities that are severe, and you can't just do the one,
I got it.
deformity driven.
I got it. Your routine exposure, median parapatellar, mid-vastus, subvastus, or something very different. Peter,
Median parapatellar.
median parapatellar.
Same always.
Same.
Yeah, same.
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 Interesting. So this is one that was a good example of lots of hype several years ago about all these other exposures, and we're all back to median parapatellar. And even though, again, my discussion about new technology, there were lots of papers that tried to suggest a difference. In the end, there really wasn't much difference, and in the end, everybody went back to median parapatellar. Do you aim for neutral mechanical axis or some sort of either kinematic alignment, personalized alignment, or anatomic alignment? Peter,
Personalized.
personalized, okay.
Neutral.
Neutral,
Neutral mechanical.
neutral.
Neutral, at times kinematic.
Okay, and what would differentiate between one you would do one versus the other?
So I think still pretty much evolving in my brain when I want to use the kinematic, but probably the lesser degrees of varus knees, I would try and go for kinematic. The more
So if they've got a kind of a mild deformity, you're willing to let them sit with a little mild deformity. Is that what
Yeah.
you're saying?
Yeah.
Okay, fair enough.
Neutral mechanical.
Okay,
Personalized.
personalized,
Neutral mechanical.
neutral mechanical.
1 degree varus for all patients, and I dial that into the femur. And in some very obese and short patients, 2 degree of varus.
Dan, one thing?
Yeah, Peter.
Valgus, I go neutral, just want to say. 0-0 for valgus knees. Maybe 1 degree valgus on the feet.
So the varus knee you're willing to personalize a little bit, but not the valgus knee. Is that right?
Yeah, 1 degree max
At
valgus.
least somebody in valgus, they hate
I
it.
hate it. Yeah.
Yeah, they will not be happy with you. Okay, now here's your opportunity to declare your religion. What are you doing for your instrumentation? Manual, computer-assisted, or robotic? And we won't talk about in whom, we'll just say what's most of your practice, and if it's only, 50-50, you can tell me that. Starting with Peter.
Move to robotic.
Manual.
Manual.
about 60% robotic, 40% manual.
How do you decide who gets what?
We offer the patient what they want, and we do what the patient tells us to do.
This is exactly why the studies are difficult to do from big databases, right?
And
So
the funny part,
that was my point earlier.
and the funny part is that a lot of patients will say, "We do not want the robo. Please do it manually."
Yeah, they trust you. Okay, fair enough. Next,
Manual.
Manuel.
Manual for totals, robotic for unis.
For unis, okay. I think that's a fairly strong trend, is that unis are moving to robotics faster than totals, because of the instrumentation, probably.
Yeah, CAS for patient with implant deformity and obesity, rest all manual.
Okay, Raj, we know where you are, I think.
So computer for all, and some percentage of patient have started using robotic.
So you're getting a computer for everybody and some get a robot. Who gets the robot, Raj?
I think at the moment it is evolving, and and the cost is so much high, so it's mainly dependent on the cost for the robotic. But I'm aiming to do.
Is that determined by which patient can pay for it, basically?
Correct.
So that's exactly what I was talking about earlier, about all the biases of the big studies.
Yeah, but-
The patient who can pay for it's healthier, smarter,
I think-
happier. Okay?
Hang on. But that is, you're talking about robotic now. The computer navigation is not so much extra. I used 100% of the patient with
I
computer
got that you
navigation.
use it. You use
And a lot of the studies, what you're saying, there is bias, but a lot of the studies are people who have used in all the population.
There's a few that do that, but not many. Okay, bone preparation on the femur. Typical angle of your cut, 5, 6, 7 degrees, or individualized based on the long-standing film? Just real quick answer, starting with Peter.
Long leg.
Long leg, okay?
Yeah, 5 most of the time, but I'll individualize if it's bad.
Okay, so
Always
usually
in-
5, but unless it's a big difference, funny shape.
Always individualize on the long films.
Okay, so you'll draw it out.
Yeah.
Okay, Sachin?
Long leg film.
Okay,
Usually 5, otherwise the long leg as well.
okay,
Personalized, particularly in obese patients, I'll drop it down to sometimes to 3 degrees, but otherwise 5.
okay.
5 degree almost always, unless the cervicotrochanteric angle at the neck shaft angle is less than 130, then it is 70.
Okay, Raj?
If I was to use a conventional technique, I would personalize for every patient. Take a distal femoral axis and know exactly what angle I need to cut.
Okay, fair enough. Rotation of your femoral component. What is your key way of choosing your rotation? White sides line, epicondylar axis, or some sort of gap balancing, starting with Raj?
I think I use all the 4 of them.
Okay, so
But my start-off point is posterior condyle, but
Okay.
the next I want to look at the epicondylar axis and the tibial cut.
Okay.
White sides line is not such an important thing.
Okay, fair enough. Next?
Gap balancing, but confirmed by epicondylar axis.
Yeah, you can make a big mistake with gap balancing on the funny knee, right? So you have to be careful about that.
So I use the white side and epicondylar axis. I don't use the posterior condylar axis.
Okay,
Yeah, same here, white sides as well as epicondylar.
okay,
APL.
okay.
Use the gap balancing, but use the epicondylar in certain cases.
Confirm yep, fair enough. Amar?
Posterior condyles, most varus knees, and then we'll use white sides and gap balancing for any difficult knee.
Okay, fair enough. And Peter?
Tension balancer, but anatomic landmarks, so with
Some
boundaries.
sort of hybrid of the
Yeah.
two?
Tension, but boundaries.
Fair enough. Give me your single best technical tip for balancing a varus knee. This has got to be a one-sentence move here, okay, guys? Because we're not going to hold a symposium on balancing. Peter?
For this knee, severe varus, reduction osteotomy.
Okay? Go ahead, Amar?
He stole my thunder.
Okay, same thing for you. Parag?
Yeah, so these are the cases where I'll keep it slightly in, whereas go posteromedially and cut more of the back.
Okay, so getting all the way around the medial side. Fair enough, Sachin?
So single best technical tip I think is complete release of the medial up to the posteromedial aspect of the tibia.
Working your way around the tibia. Fair enough?
Complete release posterior middle corner.
Okay?
Ransal maneuver, osteophyte excision, and reduction osteotomy.
Okay, good.
Undercut if there is a bone loss.
Okay? So you're going to leave them a little bit less corrected? Go ahead, Raj.
Get rid of all the osteophytes
Yep.
and the expanded medial flare or the medial tibial condyle.
Okay, fair enough. Excellent comments there. And I will just add that one technique that I think has really become valuable is the pie crusting of the MCL with a needle. I was a skeptic about that, but as we incorporate it into our practice, I can tell you it is a really valuable technique for fine-tuning your balance. Amar?
Yeah, I did that for many years. I actually published on it as well. But then now with all this kinematic talk out there, I actually now just cut it 1 degree of varus.
Yeah, well, you can cheat now with the bone cuts a little bit. Fair enough. I think we'll skip this one. How do you test flexion stability in surgery? Raj?
So I think the gaps, of course, the medial and lateral has to be stable, and extension and flexion. I use the spacer blocks
You use spacer blocks. Do you do anything to actually test the stability with trial implants in place to make sure that it's stable,
So I
even though
think
the gaps were equal?
if you reach the trialing stage, then I think you really committed quite a lot. And with the spacer, I am able to check before I'm,
Okay, so, but let's just say you've done your spacers, they look good. Do you check it after that, or you don't?
so I think I check the spacer I do a proximal tibial cut, distal femur cut. I know my extension gap. Now with the flexion, once I put my 4-in-1 block or whatever block, before I make a cut, I check what my flexion gap is going to be.
You trust the flexion and extension gap measurements more than you trust your hand and feel. Is that what you're saying?
Before I make a cut. And
Okay,
then once
fair
I made
enough.
a cut, I recheck it, and I know that some of the cuts with the posterior osteophytes is going to open up more than the other. So there are a
Okay.
lot of parameters, but I think I check it twice.
Okay, fair enough.
Make sure complete osteophytectomy at the posterior part of the femur.
Okay,
Spacer block with a rod on it, and put your fingers on collaterals and see how much they are opening and feel them.
okay, Ashok?
So I do the femur first, and I check my stability with the implants in place
Yeah.
in 30, 60, 90, and 120.
I think it's really important. I'm glad you said that because I think that just measuring is not enough. You want to feel it and know what it feels like. Okay, next.
Usually, if I get a mid-size in the femur, not a 3, not a 4, somewhere in between, I usually try with the flexion block, and then depending upon how comfortable, I go up or down, and that sort of decides my flexion gap. And while trialing, of course, check it in full
Fair
range
enough.
of.
So you're doing your gaps mainly, okay? Sachin?
Yeah, so I'll put my femoral trial on. On the tibial side, I'll just use insert. I won't use a tibial tray. And I'll go with a flat tibial insert and move it around and try and see if it spins off. If it's spinning off, then I know there's some mid-flexion instability that's happening, which I need to then take care of.
Okay?
I'll use the spacer
comment.
block and the tactile sense, move it at 30, 60, 90 degrees and just get a feel of
You're
it.
doing
and-
both.
Yes.
Okay, Amar?
So the point I want to make is, we always talk about having equal flexion extension gaps. If I'm doing a PS knee, I don't want that. I want a tighter flexion gap than my extension gap.
Completely agree with that. That's 100% right. The patients are unhappy if they are left loose in flexion. Everybody,
Tolerate equal, but I don't want it.
everybody thinks a loose knee inflection is good because they get easy range of motion. Those patients, if they have any level of activity, will not be happy. Peter?
Yeah, spacer block, and to your point, I like to have a little medial pivot on the spacer block. So you put the spacer block in, you rotate it,
Feel it's a little snug,
it's a little medial pivot.
okay?
Yeah.
All right, now let's talk about TKA fixation. We have to keep moving because of time. Cemented or uncemented, and what percentage? Peter?
85% cemented, uncemented males less than 65 with minimal deformity.
Okay. Amar?
Yeah, the same, and it's growing 15, 20% now.
Okay.
All cemented. We don't get uncemented in India yet.
Okay.
Yeah, I think all cemented, so you can.
Anybody from India
Don't
doing
bother
any
asking.
uncemented knees on the panel? Ashok, you are.
I have done a few TM uncemented knees,
Okay.
but they're not easily available. But for a very select group of patients, I have done uncemented.
Anybody else from India doing any uncemented knees? Raj, no?
I did when I was using LCS about 25 years back. Some
Not
of the
now.
sizes came only in uncemented, now, not now.
Okay, is that because they're not available or because you don't believe in it?
No, they are not available.
Okay, fair enough. So this is not yet a big relevant discussion in India, but will become one very soon. Because I'm sure that once they're available, there'll be a lot of enthusiasm and excitement for it because it's relatively fast.
So, Dan, is
Whether
there
the
a-
results will be as good, we don't know. Go ahead.
Is there a trend to move towards uncemented in the United States?
There are many more uncemented knees being done in the United States now than there were 5 years ago, partly because there's a lot of new designs available, partly because people think it's faster, I think, to be honest with you. But we'll wait and see whether the results hold up. That's, I think, uncertain. Omar, you had a comment?
Yeah, so I said that before. Like my tibias don't fail. My cemented tibias. I haven't had a loosening. I've only put probably in a couple hundred non-cementeds, and I have 2 BMIs over 45 with tibial loosening.
Yeah.
And so my thought is I probably should have done what I would have done in cement was put a big stem on it, and I should have probably had a stem on those.
My prediction is that in North America, we will overshoot and we'll do too much uncemented knees, and then we'll have to back off again. If you have a high BMI patient, do you use a small stem on the tibial component to try to protect it? Very quick answers because we're running out of time. Peter?
Always.
Always? Amar?
No, because the implant I use has a pretty long stem.
Okay, so you don't need one, okay? Most of the time?
Yeah, always.
Always?
Depends on the bone quality.
A poor bone? Fair enough?
Greater than 35 views, short stubby stems fully cemented.
Okay.
Greater than 40, small stem.
Over 40, you will. Most cases in primary need, you use CR, PS with a post, some sort of ultra-congruent bearing, or medial stabilized. One-word answers, please. Raj?
PS,
Yes.
the post, yeah.
PS always.
Medial congruent.
Okay.
PS with a post.
Ultra congruent.
PS, we are trained by Dr. Ranawat.
Yeah?
I was too, but everything's changing. I don't know what my answer is now.
Okay. You don't know what you're using?
It's a little bit of everything now.
Okay, fair enough, Peter?
More medial stabilized.
So there's definitely a trend in the United States to gradually move a little bit away from PS with a post, to be honest with you. And there's interest in both CR as well as medial stabilized, with medial stabilized probably gaining the most ground fastest.
I mean, like big deformities, it's PS post, no problem. But like, mild deformities, all those other ones.
Maybe not. Okay, fair enough. Patella resurfacing, routinely, selectively, or never? Starting with Raj, single word answer, please.
Routinely.
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 Never.
Never. Okay.
Selectively.
Yeah, routinely.
Have done all three, but now routinely.
Okay.
Routinely in PS knees, selectively in other knees.
Okay.
Same.
Okay, fair enough. So most people are resurfacing the patella routinely. In North America, there's a little interest in doing a little less patella resurfacing, but I don't know how long that will last because some of the people that were big advocates of it are now back to resurfacing. So we'll see. Wound irrigation with an antimicrobial, such as dilute betadine or something else. Just a quick one-word answer. Do you use anything other than saline, Peter?
Dilute betadine.
Betadine.
Just saline.
Saline.
Just saline.
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 Just saline.
Betadine.
Saline with antibiotics.
Okay, saline with antibiotics. Okay. Drains, yes or no, in your primary knees? Raj.
One deep drain for 12 to 18 hours.
Okay, let me do it with hands so we can be fast. How many use a drain still in the primary total knee? 3 of you. In North America, they're mostly going away. They're going away faster in the hip than the knee. I don't know if that's right, but that's what's going on. I think we will skip that question. Are any of you doing anything other than a local cocktail around the knee? Are any of you using a peripheral nerve block in the knee? Hands up. Okay, is it a selective nerve block? Or is it a, yes, selective? Okay, Adductor canal.
We use the IPAC.
You use an IPAC, okay? Peter?
Both adductor and IPAC.
Okay, so you're doing both. Extended antibiotics. Do you give extended oral antibiotics to high-risk patients? Raj?
No.
No. Is anybody on the...
7 days, but I might continue for next 3-4 days for a high BMI. More than 40 BMI patients, I would probably, but
You do?
not more than 7 days.
Okay, but so you do actually? Okay. How many people do some form of extended antibiotics in high-risk patients? Hands up. About half of you. This is an area of a lot of controversy in North America. Anybody still using CPM? Put up your hand. CPM's dead. Do you do any outpatient total knees? Both North Americans, nobody yet in India on the panel. Postoperative physical therapy after your total knees, how many do that? Hands up. Everybody? Very good. Favorite DVT prophylaxis, how many of you are using aspirin? Hands up. How many of you are using something else? When you're using something else, what is it? Just quickly down the line.
So while they are in the hospital, it is the
Quick answer, Raj. We got 1 minute.
yep, and then the oral Xarelto, rivaroxaban, I think.
Okay?
Enoxaparin intraoperative.
You're giving low molecular heparin.
Yeah, Clexane for 3 days, followed by aspirin orally for a month.
Okay?
Yeah, TED stockings for a month and aspirin.
Okay. Here's our last question. Antibiotic prophylaxis for the first 1 or 2 years or forever? Peter?
Forever.
Ever?
Forever if tolerate.
Yep.
For 1 or 2 years, and then if there's any procedure, only at
Okay.
that time.
I think forever.
Forever?
For a very short time.
Okay.
Forever.
Forever?
Short time.
More time?
First 1 or 2 years.
First 1 or 2 years. So this has definitely been a gradual change. All right, ladies and gentlemen, the floor is open to you for questions from the microphones. Please step up. We don't have a lot of time, but we want to get your questions. Yes, sir. Right up to the microphone.
Sir, TKR in a TKR in a Parkinsonism patient. Are you going to improve on the anchorage or are you going to improve on the constraint?
Sorry, which kind of patient?
Parkinsonism or where you have spasticity.
Okay, so anybody want to take that? Raj, you got an answer to that question?
Yeah, so I've done about 50 to 60 Parkinsonism patients. The standard process is no difference. The only thing is that you be aware that you don't want to be too tight in these patients.
The Parkinson's patient?
Yes.
Yeah, and you have to make sure they get out to full extension, right? Because they want to go back to that crouch gait. Sometimes they do anyway. Yes, sir.
A question to Amar regarding the BMI. So you're saying you need to look at where is the fat distribution. So BMI is about complications like infection and other secondary complication. So the size of the limb doesn't matter. As you're a good surgeon, you can execute it. But we always say you should look at where is the fat. I'm more worried about the general inflammation and metabolic syndrome rather than the size of the limb.
Anybody want to comment on that, Amar? I think that was addressed to you.
Yeah, I mean, I'm not sure what the question was, but I basically look at every patient and I sort of assess how difficult is it going to be for me to do the surgery. And if I go, no problem, then no problem.
Okay.
And if I get nervous, wow, you should get nervous.
Okay, we have time for 3 quick questions. Microphone 5 first.
Yeah, is there a role of pre-operative shot of tranexamic acid, those who are using tourniquet?
Sorry, I didn't catch the question. Did
No,
somebody
it
get
is given before the tourniquet all the time, 1 hour before, 1 gram.
Most of the time
IV,
people are giving the
and
1
then you
gram
put the
at the start.
tourniquet.
Then the
Before the
tourniquet is on, then how it will work?
That's the other benefit of the tourniquetless exposure, is that the antibiotics can, go in.
Everybody would agree that when you give the antibiotics, it has to be well before the tourniquet goes up, right? No doubt about that. Yes, sir, middle microphone.
Any comments about the asymptomatic pyuria? Does it change? Because most of the panel said...
Okay, great question. So if you get a UA and the patient's asymptomatic and you've got some white cells in there, what do? Raj, you're getting UAs on everybody, so why don't you answer?
Every patient, and if the patient is asymptomatic, but the pus cells in the urine is more than 10 or 12, I would get a urine culture done.
So you'll stop the surgery, you won't do it the next day?
I won't.
Okay.
So then that's why I do it a week or 10 days before.
Okay.
All my patients are assessed in the pre-op clinic.
So you
10 days
see them
before.
well ahead of time, so it doesn't mess up your schedule. Fair enough. Last question, over the far mic.
Thank you. Yeah. So so you said the pain management. So whether IPAC or adductor canal block, daycare surgery, and long-term stay.
Sorry, I didn't get the question.
So whether which one you think is better, an IPAC adductor canal block when you do a daycare surgery.
Okay,
IPAC versus adductor
canal.
The IPAC block has been a game changer.
Remember, they're blocking different parts of the knee.
They are, but we've basically shown, we have multiple studies, but one of them shows no added benefit of the adductor canal, and another one shows an added benefit of the adductor canal. But the real benefit has been the IPAC block.
Okay.
So I think that's been, and what it also does now, when I have my intra-articular injection, I don't inject the posterior capsule anymore, which I used to do a lot.
You've got the back of the knee covered with your IPAC block.
So more of IPAC block in daycare surgery as well, you say?
Yeah, it has no functional deficit.
The main problem with the IPAC block is that a few patients will get a nerve out for a while, and that will scare you. All right, ladies and gentlemen, I apologize.
Well, it won't if they have perfect pain control.
What's that?
So I'm saying that when they have perfect pain control and they have a foot drop, I'm like, it's the block.
Okay.
When they're hurting and they have a foot drop,
You're worried.
Then you're worried.
Okay. All right, ladies and gentlemen, please join me in thanking the panel for their efficient and excellent responses. Enjoy your coffee break.
And thanks, Dan, for conducting such a lovely session. You got a lot of information in a short time.